Good morning, friends. I welcome you all for the Nair Hospital centenary celebrations. Nair Hospital is celebrating the centenary year. The Department of Urology is the youngest specialty department in the hospital and one of the youngest urology department in the city of Mumbai. It was commissioned in 1990 under leadership of Dr. Shobha Lal, and thereafter the MCH program started in 1992. In last 30 years, we are proud to have achieved a respectable status in the Urology Association of India. Students from this institute have done amazingly well in India as well as abroad. We thank the Municipal Corporation of Greater Mumbai, past deans and the present dean for making this possible. The department is complete in all aspects of urology education. It is one of the leading departments for the transplant program, endourology, laparoscopic urology, pediatric urology, and uro-oncology. We have two specialty OPDs, the pediatric urology OPD and the andrology OPD. All this has made the patient care complete in our city. The OPD attendance runs to the tune of 200 to 250 patients on 2 OPD days in the week. We have a very good waiting list for all the procedures, and we try and achieve to give the patient the best minimal invasive care in all aspects, in laparoscopy, in stone disease, in kidney transplant, and we are proud to say that it is one of the best departments in the country. As a part of centenary celebrations, we are having various presentations in urology today. We have our guest speaker, Dr. Ganesh Bakshi, Professor and Head Uro-Oncology at Tata Memorial Hospital. He is an alumnus of our institute and he is going to speak on various aspects of uro-oncology. With this introduction, I start today's program, my first talk on cadaver organ donation. Today, I'm speaking on a cadaver renal transplant, giving a patient a new lease of life. The talk is mainly aimed to create awareness amongst general population and also our medical fraternity on sensitizing them for the cadaver organ donation. And what I mean is that in spite of the Human Organ Transplant Act, which was passed in 95, last 25 years, we have not had a significant progress in cadaver organ donation. And what we need is that we need to sensitize the general public at large and also our medical fraternity. Why? Because we have significant number of brain dead patients which are either not identified or finally, even after identification, they don't end up in organ donation. So this is the anatomy of urinary system, the kidneys and the urinary tract. So the kidney functions are mainly for the regulation of water, electrolyte balance, pH, and it plays an important role in normal blood pressure maintenance. It removes the waste from blood and important role in the excretion of urine and the waste products. Also, it secretes hormones, the erythropoietin, renin, and vitamin D3. What are the options for end-stage renal disease? One, which we all know, is hemodialysis. Second option is the continuous ambulatory peritoneal dialysis. And lastly, kidney transplant. This is the load of end-stage renal disease in India. 150 to 200 per million. It is the crude estimated and age adjusted. So with this present Indian population and Mumbai population of 18.4 million, we have nearly 25 lakhs end-stage renal disease patients in India, of which nearly every year about 4,000 get added in Mumbai. There is no regulatory body or regulatory registration in India. So these are just a rough estimate. These are the various available data published in the various conferences, and the current status of end stage renal disease in India and Pakistan. What we see at these are the various main etiologies of CKD in India: diabetic nephropathy, hypertension, chronic glomerulonephritis, and other diseases contributing for end stage renal disease. This is the CKD registry in India, which was available from 2006 to 2011 in the various Indian Society of Nephrology meetings. And the data only, in spite of all the efforts, the data which could be received was only from these major centers. So what are the economics of dialysis? When we come to see why is kidney transplant better than other modalities for renal replacement therapy? First and foremost is the very few dialysis centers, dialysis machines, cost of dialysis per month, cost of dialysis per session. And if you see here that there is a lot of discrepancy between the available dialysis facilities, number of transplant centers, and finally, the number of transplantations done per month and per year. So when we see that amongst all the available modalities, kidney transplantation is the best option for renal replacement therapy. Kidney transplant, the cost is the initial cost involving the surgery and the post-op period, and thereafter the immunosuppression and follow-up. So the cost in a general hospital or a government hospital comes to the tune of about 1 to 1.5 lakhs initially, which is subsidized by the government. And the advantage is that the patient after transplant, he goes back to the society and does a proper earning for the family and the society, and there is total rehabilitation, which is just not possible in a patient on dialysis. And if you see the survival of 10-year survival of a transplant patient is nearly 86%. And if you compare the transplant outcome as against the dialysis, when at the end of 5 years, you have more number of patients living with transplantation than those on dialysis. So the options are either live related or the disease donor or the cadaver organ. There are a lot of hurdles with live related transplant. One is the availability of suitable donors, blood group matching, the hypertension, diabetes, presence of hereditary diseases, and most important is unwillingness to donate an organ. So the next option and the best option is a cadaver organ donation or a disease organ donation. So once a patient is identified as a brainstem death, there is organ retrieval and finally ends up with a somatic death. What happens is after or cadaver organ donation, what the patient can give is 2 kidneys, 1 liver, pancreas, heart, intestine, skin, lungs, bone, tendons, cornea, and heart valves. So extending from live related, that is 1:1 ratio, we have 23, 1:23 ratio, that is the availability of organs. And what happens is that for this cadaver organ donation, public is ready, but it is not fully sensitized. It is not aware completely, but it is much better than what it was about 15 to 20 years back. These are the various available Times of India clips on the efforts which have been made by various departments, various organizations to sensitize the public for promoting them to give cadaver organ donation. Because a person may sign a donor card, but finally the organ donation consent has to be given by the near relatives. So the general population has to be sensitized regarding organ donation. So these are the various programs which have been held over the years, in last 25 years, in the form of media, Times of India group, publications, various newspapers, and sensitizing the society by donations which have occurred, and feeling the family, making them proud, and also society, so that the further patient and the relatives would agree for cadaver organ donation. So these are the various ways the media can help in sensitizing the public. Also, the available of tissue donation and uh, availability of the tissue bank. Now, coming to what is the present state of organ donation in India, if you see that Tamil Nadu and Kerala have had the highest number of organ donations. They are much, if you see here, there are nearly 4 to 5 times more than Maharashtra and Mumbai. So organ donation in Mumbai, this is the figures of 2019, 2020, 21, because of COVID, there have hardly been any organ donations. And very, very small number, if you see, of donors, only 53 kidneys, 25 livers. So we need to multiply at least 10 more times to achieve a respectable status. Because, you have these clips also where we have really lagged behind in cadaver organ donation. So this is, the personalities who sign up the organ donation card. So it's time that the public sector hospitals walk the government's talk. Each organ donated is one life saved. There cannot be a public sector, private sector divide in sharing this social responsibility. That is because even today, it is the corporate hospital who have taken a lead and been responsible for nearly 95% of the organs that have been available for organ donations. Outside India, as you all know, that live related transplant takes only 5% of the total program, whereas the 95% is with the cadaver program. This is the waiting list in Mumbai for kidneys. This is the workload of nephrology. And since 95, we have had only 2 or 3, cadaver brainstem death patients. Retrievals have been only in 2 patients. So we have lagged very, very much behind, and we need to step up in this. So the awareness of organ donation will boost the program. Now coming to what is brain death? Brain death is where that the brain functions have ceased to occur. Only the cardiorespiratory function is going on, so that the organs are being perfused. But if organ retrieval is not done in stipulated time, in 24 hours, 48 hours, finally, even the cardiorespiratory failure is going to occur, and we will not be able to retrieve any of the organs. It is needed because that if we don't retrieve, I diagnose brain death, then we would not get these organs. And coming to later on, how to diagnose, who can diagnose, and what after diagnosing the brain death. So American Academy of Neurology in 1993 gave a standard approach in US with substantial variability by diagnostic criteria. The Indian Human Organ Transplantation Act was adopted in 94 with amendment in 2014. So the diagnosis in any comatose patient, there are prerequisites with inclusions and exclusion criteria. On clinical examination, absent motor response, absent brainstem reflexes, apnea test. Once this is criteria are fulfilled, we undergo the diagnosis of brainstem death. If it is yes, we go with retrieval of organs. So the prerequisites are that the cause of coma is established. Patient must be on ventilator. There's an observation period of about 6 hours. These are the exclusions: hypothermia, drug intoxication, neurology diseases, and endocrine crisis. So these are the criteria for brainstem reflexes and apnea testing. I'm not going to go into details of all this. Once the presumptive diagnosis is made, after 6 hours, the tests are repeated. And once the final diagnosis is done with the team of neurologists, the neuromedicine, neurosurgeon, concerned unit, physician or surgery, the hospital administration, finally, the appropriate authority. And once that is certified, the zonal transplant coordination committee is intimated. It is intimated immediately when there is a patient of a probable brainstem death. Once these are were once upon a time recommended, these are no more recommended as the days. Once it has been done, once first is the identification of a patient who is brain dead in any ICU setting or trauma setting. And here comes the role of the transplant coordinator who sensitizes the relatives that yes, your relative does not have a chance of survival. And the best option for you is for you to see that your relative is living with his organs by donating the organs. So here comes the role of talking to the relatives, establishing a rapport with the relatives. And thereafter, once the relatives they agree, next step is the consent for organ harvesting or retrieval and multiple organ donations. Donor management is very, very crucial once a patient of brain dead is identified, because there have been umpteen instances where a patient is identified with brain dead, but we lose the patient in the intervening period because of improper donor management. So it consists of maintaining adequate blood pressures, urine output, CVP, hormonal replacement, and so on. So once the brain death is certified, the next step consists of organ procurement. So the team, the transplant team is intimated, and appropriate team, that is for the heart and lung, for the liver, for the kidneys. So it's a multi-speciality team which will be there on the scene, which will procure the organs. Once the organs are procured, they have to be stored properly. After the storage comes the distribution. The distribution is the role played by the Zonal Transplant Coordination Committee. They have a list of the various donors who are waiting for various organs, and at least 2 or 3 potential recipients are intimated well in advance. And the one, because many times it so happens that the patient who is first on list may not be available, may not be a suitable candidate. So the next patient is tested, third patient is tested. So normally about 3 to 4 patients are informed, they are called, they are dialyzed, the lymphocyte cross match is sent of at least 2 or 3 patients in each center. And once who is the appropriate patient gets the organs. So coming to this cadaver organ transplantation program, we have been very, very slow. We have been lagging behind a lot. We need to have awareness, not only in the society, in the medical colleges, with the medical fraternity, the trauma wards and the ICU personnel need to be sensitized for diagnosing brain dead patients on time, so that the transplant coordinator comes and he speaks with the relatives, and the intervening period, which is very, very crucial, is maintenance of the donor is adequately done. So the transplant coordinator comes and would develop a rapport with the relatives, coordinate with the zonal transplant coordination committee and with the transplant team. So with this brief introduction to cadaver organ program, I thank the Nair Hospital Centenary Committee for having given us an opportunity to be a part of this program. Now I'll invite our next speaker, Dr. Mukund Nandankar, who is a professor in the Department of Urology for last 20 years. He's one of our leading team members in the department and has actively contributed to the laparoscopy program, to the endourology program, and the transplant program. I welcome Dr. Mukund Nandankar.
Good morning, everyone. Thank you, sir. Thank you, Nair Centenary Celebration Committee, for giving us an opportunity to be here today. Next 10 to 15 minutes, I'll try to cover catheters and catheterization. Catheterization is a very commonly done procedure in the hospital by all the doctors and nurses. And my talk is aimed at our non-urology colleagues who do this procedure day in, day out. The scope of this talk is divided into 4 topics: types of catheterization, types of catheters available in the market, modes of catheterization, tips for difficult catheterizations, and common issues associated with catheters faced in the wards every day. Catheter in Greek means to let or send down. The first urinary catheter is reported to have been passed by John Gaddiston in 1300 to 1367. But it was Dr. Frederick Foley, a surgeon working in the Boston when he was a medical student, who designed a Foley catheter, which was manufactured by Bard as a first prototype and was named in his honor. There are several indications of catheterization, including diagnostic evaluations, therapeutic short-term catheterizations, therapeutic long-term catheterization. But are there any contraindications for catheterization? Although not absolute, but it should not be done, or it should be avoided just to determine the presence of infection, to collect urine samples to determine whether there is infection or not in kids, to measure post-void residues. As a routine order, most of the times in ICUs, it is done to monitor output, especially in non-critical patients. Why are we concerned about catheters? Because it's a foreign body after all. It can cause trauma, can lead to infections. It is the fourth most painful procedure after nasogastric intubation. You'll be surprised. Bacteriuria is a matter of time. Within 4 days, almost 30% patients will have bacteriuria. Up to 25% of the hospitalized patients are catheterized, and sometimes unnecessarily. And urinary tract infections account for around 23% of hospital-acquired infections, out of which 80% are in presence of a catheter. It can damage urethra, leading to scarring and strictures, and can lead to bladder cancers, so promiscuous cancers, if the catheter is left for years. There are different modes of catheterization. Condom catheterizations, indwelling catheters, intermittent, and suprapubic cystostomy. Condom catheters are meant for men who are able to void spontaneously but have restricted mobility or dementias. So it should be used in such patients whenever you need a catheterization. It is more comfortable, less painful, and less restrictive for the patients. It has lower risk of urinary tract infections than indwelling catheters. However, the disadvantage is it can cause urinary leakage, especially when patient starts moving around, and can have skin breakdowns over penis if it is tightly fitted and is neglected for a period of time. Therefore, one caution is whenever you apply a condom catheter, please assure that you examine the penis or you replace it or change it every 24 to 48 hours. Next come urethral catheters, which is, let's talk first about intermittent catheterization. Intermittent catheterization per urethral is advised to patients who are unable to void spontaneously, like in urogenic bladder, myogenic failures. These patients are unable to void spontaneously and need catheters for a long period of time. They are taught self-catheterization, which is done every 4 to 6 hourly, and intermittent insertion of catheters minimizes the irritation to urethra and ascending infections. The principle of clean intermittent catheterization is based on the principle that most infections are due to underlying structural or functional abnormalities rather than introduction of bacteria by catheters. We are worried about the catheterization causing infections, but CIC has less infections than indwelling catheters. Patients are instructed to wash the catheter with soap and water and dry the outside and store them in a clean container for reuse. The intermittent catheterization has several benefits over continuous catheterization. So it should be encouraged that, especially in those patients who need catheters for a very, very long period of time. Next comes the suprapubic cystostomy. SPC is done either as an emergency procedure when you're unable to catheterize for some reason, or it is preferred in people who cannot do self-catheterization but need a catheter for a long duration time. It has an advantage of insertion, maintenance, and changes being very easy. And incidence again of UTI is lower as compared to per urethral catheterizations. It is done midway between the umbilicus and pubic symphysis. And we have trocar and cannulas, which are readily available in the market, which are used as SPCs. However, as an emergency, if you're stuck with a patient who has retention of urine, is howling because of pain, and you do not have access to catheter, or you're not able to catheterize, and you don't know how to do SPCs or suprapubic catheterizations, you can simply do suprapubic aspiration in an emergency in the suprapubic in the point which is midway between SPC pubic symphysis and umbilicus, and send the patient for or call a urologist whenever they are available. Per urethral catheters comes next, which is very commonly done procedures. But how do we choose a catheter? First thing you should think about is, why do I need this catheterization? Does this patient really need it? How long do I need a catheter? Which size is adequate for this patient? Whether should I use silicone catheter, latex catheter, or some antibiotic impregnated catheters? Let's see one by one. There are different catheter materials available, right from PVC, silicone to soft red rubber catheters. Red rubber catheters are extremely soft, are rarely used and rarely useful for perurethral catheterization. PVC catheters are stiff. At the same time, they are flexible, and they are used mostly in self-intermittent catheterizations. There are natural latex rubber catheters, which the Foley catheter can be made of. They are flexible and inexpensive, but they are more prone to infections and toxicity, and they can be used for maximum 15 days. Then we have all silicone or silastic catheters. They cause less inflammation in the urethra, less incidence of urethritis and strictures, and they can be used up to 12 weeks. The advantage of silastic catheter is it has a wider lumen, therefore it drains purulent urine better. And it has a stiffer, it is little stiffer, so it can negotiate the strictures better. Then we have silicone or coated catheters, or elastomer or silco-latex catheters. These are very commonly available catheters even in our hospitals nowadays. So these are latex catheters coated inside and outside with silicone. So it combines the strength and flexibility of latex and durability and reduced incrustation properties of silicone catheters. So that, I would say, is preferable in nowadays, if at all, if it's available. Then we have coated catheters coated with different materials like silver, antimicrobial, hydrogel coating, etc., but they are hardly of any use. Different catheters can be used for different purposes, and we always get this question: how long can we keep this catheter? Remember, simple Foley catheter can be left behind for around 15 days, but silicone or silco-latex catheter can be left behind for around 6 to 12 weeks. However, remember that none of these catheters prevent biofilm formation, which is the main culprit in urinary tract infections. Hence, it is usually advisable to change the catheters within 2 to 3 weeks to prevent UTIs. Next comes the question, which size catheter should you choose? If you find out that catheter and effective drainage studies done by different authors, 14 French catheter is more than important to drain clear urine and is recommended for routine use in adults. 16 French and larger are used for urine containing debris, and 18, 20, 22 leave it for urologists to be used after needed for hematuria and clots, or even after surgeries like TURPs. There are some special catheters like these which have curved tips, and they are used to negotiate difficult curvatures of male urethra and high bladder necks. There are single-way catheters, two-way catheters, and three-way catheters, depending on the purpose for which you need to use it. So, for example, the three-way catheter is needed for irrigation. If patient has hematuria, we usually put a three-way catheter where one channel is used to facilitate continuous bladder irrigation. Coming to different accessories which are available. Commonly used urine collecting bags. Please choose a good quality bag which has a kink resistant tubes, because a lot of times we see when the patient is sleeping or moving around, the tube gets kinked and the bladder fills up. Please change them weekly at least and empty the bag when it is 2/3 full. Don't wait for it to become completely full. There is something called a leg urine bag available. This is extremely useful if you want to send the patient home on a catheter. This leg bag can be tied to the leg of the patient, and patient can wear loose clothes over this without having to carry his urine bag in the hands, which is a very embarrassing situation for these patients. Coming to catheter insertions procedures, I'm not going to go into the details, but just wanted to emphasize in few points that please ensure that new jellies, new tubes are available, single-use packets. These are single-use packets. Most of the times when we go for catheterization in different, at least especially in medical wards, we see the used jelly tubes being used, and just the jelly is just applied on the tip of the catheter and catheters are inserted. Please don't do that. Have 2 new single-use packet jellies available and different size and type of catheters available on your trolley. Please maintain sterile precautions. It's a sterile procedure. It has a potential to cause bacteremia and infections. So maintain all sterile precautions. insert at least 20 cc of the jelly in the urethra and wait for it to have its effect. Never ever force the catheter. Use gentle pressure. When do you fill the balloon? Well, the catheter is advanced till Y junction, and till the time you see free flow of urine, don't infill the balloon. If there is anuria, patient's catheter bladder is not full, see to it that there is free irrigation and aspiration, then only fill the balloon. Till that time, please don't fill the balloon. Fix all catheters. Retract that prepuce. We have seen a lot of calls wherein there are paraphimosis, and we had to do a circumcision or even incisions to release the paraphimosis in emergencies. The fixation of catheters to either the abdomen or the thigh reduces unintentional motions and reduces accidental dislodgements, pulling the catheters and causing urinary bleedings, and reduces the adverse events. Next comes the question, how much fluid should be instilled in the balloon? Well, the smallest volume which retains catheter in the bladder that is the answer. If you insert larger volumes, the larger volumes can cause bladder spasms and leakages and residues. So, and if you underfill it, it can cause kink of the tips and lead to blockage. So a 14 French Foley catheter and 10 ml balloon is the standard ideal for routine use. Coming to difficult catheterizations. We as Department of Urology face approximately 15 calls every month for difficult catheterization, maybe more. Most of these are from medicine department, ICUs, and casualties. If I roughly divide, 5 of these 15 walk in easily with enough lubrication. That's the only thing, the first basic step. 2 of those 15 will need a stiffer silicone catheter to negotiate a little smaller urethra. 2 of them will need suprapubic catheters because this catheter doesn't walk in. And around 5 to 6 will need some kind of manipulations over the wire. We attend around 2 to 3 calls per month of bleeding per urethra due to Foley balloon being inflated in the urethras or even accidentally pulling out. So what should you do if you're faced with a difficult catheterization? First, assess the patient, find out why does he have any history of surgery, etc. And which part of the urethra is difficult to negotiate. Is it the first 2 centimeters? It is the around 18 to 20 centimeters, or is it at the prostate or bladder neck? Depending on, there are different manipulations which are available. You can, if it's a meatal stenosis, you can simply cut the meatus and pass a catheter. If it's a false passage or difficult catheterization, catheter is not moving out, one of the easiest way to do is insert a hydrophilic glide wires. They are available in our hospital, and pass it well into the bladder. If it comes out like this, it hasn't gone in. But if it, after passing this glide wire enough, if it goes in straight, then you can, by Seldinger techniques, pass the Foley catheter over a guide wire and guide it into the bladder. If it is because of a stone like this in prostatic urethra, just instill 50 cc saline and advance it forcefully under pressure and it walks in. Then another trick is, if you are finding it difficult to negotiate bladder neck or prostate area, there is something called 3-hand technique. I mean, your colleague will help you giving a perineal pressure or passing a finger in the rectum and raising the prostate so that it guides the tip into the bladder. If there are multiple false passages, they are left. We have something called filiform bougies, which help us in negotiating these catheters. This is a common catheter guide which is available, and most of the residents, general surgery residents, have seen this. But I've put in this slide to warn you, please avoid this if possible, because it has a potential to cause false passages and leading to bleedings. There are several adverse effects and complications of catheterization, but I've picked up few common issues with the catheters for which we get calls. After catheterization, say if there is no urine in the bag, what do you do? First thing is check for the kinks, check the hemodynamics, whether the bladder is full or not. If the bladder is full, still it is not draining, and you've done all bladder wash and you've ruled out the obstruction, change the catheter. There is a pericatheteric leak. We get a lot of calls for pericatheteric leak. One of the common causes for pericatheteric leak is large balloon size and large catheter size. First thing you do is downsize the catheter, put a smaller size catheter. As I said, 14 French catheter with a 10 ml balloon, most of the problems will be solved. Catheter being pulled out and patient has bleeding. okay, you attend the bleeding, find out if it is profuse or not, check for hematoma. You can do one skilled attempt at reinsertion, but otherwise, simple perineal compression is enough. Give a perineal compression and wait, and then ask for help. Catheter care, routine catheter care in different patients. Ensure that there is a continuous drainage, fluids and tubings are open. Fix the catheter with the patient to the bed. Antiseptic dressings, antibiotics routinely, and perimeatal dressings is a big no. No need. You can tell the patient to take a bath and wash the catheter as he takes a bath and keep it clean. Just keeping it clean is the mantra. Catheter removal. Ensure that patient has antibiotic cover, because even removal of a catheter can lead to bacteremias. And most of the patients who are catheterized and are on a catheter for a few days, especially post-operatively, ensure that they have cleared their bowels, there is no constipation, they are adequately mobilized. And in elderlies, you are given alpha blockers to around at least 48 hours before to avoid these patients landing up in retentions. We almost, a lot of times we see should bladder training or clamping Foley catheter before removal. Seeing this practice is quite rampant, and I've seen it being done in orthopedics and surgery, some of the surgical departments. Just to tell you that there is no role of this procedure. It is not needed. Just remove the catheter and observe. There's no need of the, clamping the Foley's pre-operate before it is removed. Non-deflating balloon. What if you cannot deflate the balloon? There is no role of installing any chemicals. Don't install any ether or anything which was done in the past, because they can lead to severe chemical cystitis. Cut above the valve, pass the glide wires, or the simplest is send them for USG guided needle punctures. We see a lot of these patients like with mineral deposits, catheter blockages, this white colored discoloration of the tubes, and catheter getting blocked. This happened because of alkaline conditions, infections because of Proteus mirabilis, and which cause precipitation of crystals. Recurrent blockages can occur. One of the most important thing to do in such patients is acidify the urine. Don't alkalinize them further. Acidify the urine with oral vitamin C. Give them increase the fluid intake. Treat their infections, and this usually disappears. Suprapubic pain, bladder spasms, another reason with when another complaint we see in these patients. Well, again, bladder spasms can occur because of lead to periurethric leak and can cause infections because of the reflux. And these occur mostly due to large size catheters or overinflated balloons. And they usually respond to downgrading the size of the catheters. But if not, you can use a couple of drugs such as flavoxate, which is a simple urinary antispasmodic and free from anticholinergic side effects. Otherwise, tolterodine and solifenacin are the drugs available, which are bladder relaxants or anticholinergics. Coming to catheter associated UTIs, it's a topic in itself, but just a couple of points important, which I will highlight here. It's a significant concern because even with the best catheter care, most will have infected urine in 10 to 14 days of catheterization. There are basically three sources of infection. One is the catheter meatal junction, catheter and bag connection, and third is catheter drainage bag outlet. At catheter and bag connection, one important thing is please do not disconnect the catheter and the bag to collect urine sample for culture sensitivity. If there are valves available, you can draw the urine from the valves. Otherwise, clean the catheter and put a needle to aspirate the urine. Don't disconnect them. And make sure that the bag is kept below the bladder level. If you hold the bag above the level of the bladder, there can be a retrograde migration of urine leading to infections. Biofilms are the main villains in CAR-Ts, or catheter-associated urinary tract infections. These develop when bacteria adhere and multiply on the catheter surfaces, and they protect organisms from antibiotics and host immune responses. All catheter types, all catheter materials are subject to biofilm development. So changing the catheter periodically is the only workable solution in such patients. We have a lot of patients who have asymptomatic bacteria. If you send the patient home and he doesn't have symptoms but has bacteriuria, there is no need to give them antibiotics as a routine case. So coming to end, just few recommendations. Insert only when the catheterization is necessary. Use condom catheters, suprapubic catheters, and CSIC, that is clean intermittent catheterization, as an alternative whenever possible. Please take sterile precautions. Wash your hands before catheterizations. Use aseptic techniques, sterile equipments. Use single packet of lubricant jelly. Don't reuse those jellies. Use smallest caliber catheter consistent with good drainage. 14 French 10 ml balloon. Fix all the catheters. Maintain sterile closed drainage system. Catheter and drainage tube should not be disconnected unless for irrigation. Collect the specimen for small volumes of fresh urine from the distal end of the catheter or the sampling port. Don't disconnect for connection of the urine for collection of urine samples. Maintain unobstructed flow. Use kink-resistant tubings. You have bags which are available with kink-resistant tubings. Keep these collection bags always below the level of the bladder. As far as meiosis is concerned, there is no need to apply cream or any betadine or anything. They just keep them clean. There is no value of regular bacteriologic monitoring of catheterized patients, as infection control measures has not been established and it is not recommended to give them antibiotics. Please retract that prepuce after catheterization, otherwise they might have paraphimosis, and avoid antibiotic prophylaxis and all. Catheterization is a routinely performed procedure. It has potential serious complications, and sterile catheterization techniques and catheter care should be properly taught during all the residencies to everyone, because behavior picked up during residencies stays with you for the lifetime. Thank you.
We would like to Dr. Ganesh Bakshi, sir. He is a past alumnus, done UG from Nair Hospital, to enlighten our audience with a talk on urologic oncology. He's a head of department at Tata Memorial Hospital. He'll be speaking next.
Thank you, Dr. Priyank. I thank Nair Hospital for giving me this opportunity, because I have been an alumnus from Nair Hospital. My MBBS is from there, and I had also been a witness to the 75-year celebration at Nair Hospital. And indeed, this is a proud moment for me. The topic is advances in uro-oncology. So what is uro-oncology? It is a subspecialty branch of medicine from urology dealing with the treatment of urological cancers. We deal with cancers of kidney, prostate, urinary bladder, testicular cancers, and prostate, penile cancers. These are the advances in imaging in uro-oncology. So CT scan is commonly used as a method of imaging investigation. And in renal cancer, modern day CT imaging helps us see the tumor better. It makes us understand the relation of the tumor to the remaining normal kidney. There is excellent delineation of the vascular anatomy, that is the blood supply inside the kidney. It identifies subtle anatomic variations, the abnormalities in the structure, and it gives us a three-dimensional reconstruction of the tumor and the renal vessels. So if you see here, this is the tumor which is shown very nicely, and in the reconstructions we can see this. This makes us easier to plan the surgeries, and we can see the vasculature. This is the blood supply which we can conserve as we do the surgeries. Also, with the CT scan and the picture, we get to see these renal masses in various sizes at various positions, and we can give them scores. Increasing number of small renal masses are being detected incidentally today as people do a lot of sonographies for various reasons. So as I said, these scoring systems are available, and they help us in planning the surgery and also in counseling of the patient. A future development, and which is already in vogue at many places, even it is gaining strength in India, is a 3D printing, which is an extension of this 3D reconstruction of CT, where imaging and preoperative planning of the kind of this renal tumor goes to the next level. It helps the surgical team accurately plan a nephron sparing surgery. That means we save the kidney in these surgeries, only remove the tumor, with intricate details about vascular system and renal parenchymal anatomy as shown here. So this is the tumor, this is the normal kidney, and this is how we can see the blood supply internally, and we can do the surgery. Coming to another mode of imaging, the MRI for prostate cancer. The use of MRI has revolutionized the management of prostate cancer. MRI helps in targeting the prostate biopsy in patients with a raised prostate-specific antigen. So if this is the lesion seen in the biopsies, we can make it sure that we get a biopsy from here. It may even help to avoid a biopsy in certain patients if no suspicious lesion is seen on the MRI in spite of a slightly raised PSA. There can be very accurate local staging, and we will come to know if the cancer is restricted to the prostate or it goes outside. There can be good nodal staging, the lymph nodes where the cancer spreads from the prostate, the location and the size and the number, and assess also the involvement of neurovascular bundle. There are nerves besides at this area, and we can see this area very clearly. If there is cancer coming into the area, it is important to plan surgeries so as to preserve the erectile function. Coming to one more mode of imaging, which is used quite commonly nowadays as an advance in prostate cancer, is PSMA PET CT scan for prostate cancer. It has virtually today replaced bone scan and is a one-stop investigation for locally advanced and metastatic prostate cancer staging. We can see the skeletal, that means the bone, as well as the visceral metastasis. Visceral means spread to the liver, lung, and other soft tissues. Cost and availability are a concern. There are some advances in pathology. So the branch specific is called uro-oncopathology. Oncopathology is a subdivision in pathology, and when we use it in urology, it goes to uro-oncopathology. A well-trained uro-oncopathologist is an integral part of the multidisciplinary team in uro-oncology, and it helps us a lot with various pathological techniques. One of them is immunohistochemistry, special stains. It helps in establishing and confirming the diagnosis in doubtful cases, thus guiding the management. There are few more advances in diagnostics, like renal biopsies can be done sonography or CT guided. Increasingly, they are done to prevent operating on some smaller masses where we can have a good diagnosis before we think of outrightly doing a surgery. Sometimes they might come non-cancer and we can prevent a surgery, or sometimes they can come very, very early stage of cancer and sometimes we can wait and watch. This is prostate biopsy in diagnostics. So we can take help of MRI, as I spoke earlier, to locate or target the regions within the prostate. And there are two methods here. One is transperineal biopsy and a transrectal biopsy. So by the latest updates, transperineal biopsy is currently preferred, but it will be more used in the time to come for prostate biopsies. There is also importance of genetics in some of urological cancers. So in kidney cancer, as you see this diagram, if this is the patient and this is the family, then we can have a connection like this. About 4 to 6% of renal cancers can be familial. The most common mutation seen is in the VHL gene, and we have to suspect familial renal cancer sometimes when the age in the patient is below 45 years. There are multiple tumors or bilateral tumors. There is positive family history, or there is renal cancer with some other cancers here and there. If a genetic test is positive, then the family members should also be screened and a services of cancer genetic clinic can be availed. In prostate cancer, when to suspect genetic base of prostate cancer, there is a young patient with a high risk of metastatic family history of prostate cancer. We do check for BRCA1, BRCA2, ATM, MLH, MSH, and MSH6. Patients with metastatic prostate cancer who test positive for these mutations today have drugs available. Although they are expensive, they provide some benefit in treatment. Genetic testing also helps in counseling about disease prognosis, making the adult family members aware of their future risk of cancer. Coming to advances in treatment of cancer, about conservative techniques. So today, organ saving is the key. Although the cancer would be in the complete in the organ, the complete organ may not be removed. Traditional surgical resection of tumors involved removal of the organ and some surrounding tissues as well, resulting in a considerable morbidity. Management of early stage tumors has shifted towards organ preservation. Only the tumor is removed in an attempt to improve functional outcomes. So as you see in this picture, if this is the kidney cancer, then only a small part is removed and we can save the remaining kidney and it will function maybe for the rest of the life. So about kidney, nephron sparing surgery helps preserve renal function, that is the kidney function. It is especially important if the patient has tumor in a single kidney by birth, or there are tumors in both the kidneys, that is bilateral, or the patient also has hypertension or diabetes or some other disease which compromises the renal function. Preservation of renal function can decrease the incidence or risk of cardiovascular events in future and thus causes improved overall survival. This is about organ preservation in penile cancer. As the photos and the picture suggests, even if there is a cancer, instead of removing the whole organ, we can remove the small cancer with oncological principles, taking safety measures so that the cancer is not left behind, and then reconstruction in a short possible way where the function of the organ will remain. Similarly, in bladder cancer, sometimes we have to do a total removal of the urinary bladder, which is cystectomy. Sometimes we can do a partial cystectomy, and there can be other procedures like radiation. In testicular cancer also, in certain conditions, we can do organ preservation, remove a small part and preserve the rest. So functional preservation is also possible in prostate cancer, where we spare the neurovascular bundles, that is called Nair sparing radical prostatectomy surgery. It helps in preservation of erectile function. It may also help to improve return of continence post-surgery, that is urinary control, and it can be performed unilateral or bilateral depending on the location, grade, and extent of the disease. Now, advances in treatment and technology. So today there are better instruments, there are better accessories helping us with good hemostasis, that is preventing blood loss while doing these cancer surgeries. There are instruments like these retractors which help us give better exposures. They help the doctors to remain fresh or non-tired as they do the surgery, and the length and the form and feature of these instruments, they help us enhance our ergonomics. That is the ability to do certain surgeries, to do certain steps within the surgeries and make our life comfortable. Then minimally invasive surgery. Commonly known surgery is laparoscopic surgeries. It is called as keyhole surgery, but again, it does not compromise on any oncological principle which would be same as the open surgeries. The benefits are we can avoid long incisions. There is early patient recovery. There is much lesser pain in the post-operative period. There is much lesser blood loss. The cost is not much higher today than the open surgery. It requires a surgical expertise and a good amount of training to achieve expertise in this. As shown in the figure, it is called keyhole surgery. So you go inside with instruments and do the surgery where is the organ concerned. The pictures of laparoscopic surgery look like this. There are these ports put and the instruments would be put from inside these ports. The surgery is done and it definitely avoids a scar on the body like this. There would be smaller scars post laparoscopic surgery as seen in this picture. Coming to an advance on the laparoscopy is the robotic surgery. Now, robotics is also in vogue and quite it's famous for its excellent vision, especially for pelvic surgeries, and also its excellent outcomes, enhanced ergonomics. The surgeon is actually the one who does the surgery. So the surgeon is the master and the robot is the slave because the surgeon controls the movements of the robotic arms which are holding the instruments, and thus the surgery takes place. There is a lesser learning curve here compared to the laparoscopic learning than when you convert from open surgery. The concerns are cost and availability. So as you see, there is excellent vision, especially for pelvic surgery. Otherwise, it would be matching and slightly better than the laparoscopic. Hence, there are excellent outcomes. We can see much more tissues in detail, and we can address much more things in very much detail to have outcomes, as I said earlier, organ preservation, sphincter saving, and other things. The robotic endorest movement has a movement which is almost like a human wrist. So the instruments inside, they have a much more angle and movement ability, unlike laparoscopy, which has a restricted fulcrum and a restricted endorist movement. These are the components of the robotic system. This is the console. This is how the surgeon holds the instruments when seen in the console. The actual vision cart where we have a screen here, this remains near the patient's bedside, and a robot with the 4 arms. The setup looks like this, where the surgeon is doing the surgery. The patient is on this bed with one assistant or a sister, and even a student can see in one more console and learn. So the learning happens well. There are few more advances in uro-oncology, which I would also talk about. Advances in radiation therapy. Like surgery, radiation therapy has also seen advances over the years. More precise delivery of radiation to only the tumor organ involved. Less exposure to surrounding organs. So there are much lesser side effects due to scatter radiation. Also, more intense delivery of radiation per sitting has reduced the number of sittings required today. This technique is called hypofractionation. It is in vogue today, and it has helped shorten the process of radiation therapy treatment. So these are pictures of image-guided radiation therapy machines, where these are gantries and tomos here with the patient sleeping. With the help of this, we can adjust at the exact spot of cancer and give good radiation. This technique is brachytherapy. As you see, there is a mesh here and needles are inserted. This is a brachytherapy of the prostate where needles are inserted, and then seeds of radioactive material would be inserted through these needles, giving radiation therapy to this part. This is called brachytherapy of the prostate. There are certain more advances, that is in the palliative care support groups in cancer. Patients with uro-oncological cancers usually have a more favorable outcome and they live long. Testicular cancer is almost curable even when metastatic with prostate cancer. When metastatic, prostate cancer patients also have a very long survival. Early stage renal cancer is totally curable. About 80% of the bladder cancers are non-muscle invasive. What happens is these patients, when they get cured, they have other issues. Somebody would have issues with fertility, somebody would have issues with marriage, somebody would have issues with certain other things, profession. And then these survivor groups today, they help patients deal with functional issues resulting from treatment and other quality of life issues. So these are active support groups in which doctors, social workers, other people participate, and they help the patient do well, especially in cancer care. As we work together in a multidisciplinary team in uro-oncology, we have the surgeon like me, we have a radiation oncologist, a medical oncologist, a pathologist, a radiologist, a nuclear medicine specialist, and social worker as well as a counselor. Today, the patient is in the center and this is the standard of care. All these advances turn finally into better patient outcomes. So there is more refined oncosurgery, more precise radiation therapy, more tolerable chemotherapy, and availability of support groups to make the cancer treatment better in uro-oncology, as well as make patients' life better. Thank you so much.
Thanks, Dr. Ganesh, for having accepted our invitation out of your busy schedule. And we are very proud that alumnus of this institute has achieved a respectable fraternity position at TMH. Hearty congratulations. And thank you once again for your excellent talk.
Thank you, sir.
And now I invite our next speaker, who is our colleague and associate professor from our department, Dr. Tarun Jain. He is one of the most important members of our family, and for his very good work in endourology, laparoscopy. So I invite Dr. Tarun Jain. He's going to speak on minimally invasive surgery for stone disease.
Good afternoon, everyone. I'm Dr. Tarun Jain. I'm an associate professor here in Urology Department of Nair Hospital. I would like to thank Pathak sir and Mukund sir for allowing me to share the dice with them. So today I'll speak not more on minimally invasive surgery, but more on how the evolution of the stone surgery has been since ages. So first of all, how and where it all started. So the first, you can say, a patient of stone was Egyptian, 1500 BC. Basically, it was a mummy in whom a dissection was done and a bladder stone was found out. So the mummy was around 4,500 to 5,000 years old. It was found in El Emara in Egypt. So that was the first case of bladder stone that was seen, or basically any stone related to kidney. Then regarding the surgery per se, the first perineal lithotomy, it was basically a surgery done for bladder stones. The incision was performed in the perineum. At that time, there was no anesthesia available, no techniques for suturing was available, and used to be done by a Roman encyclopedist. His name was Cornelius Celsus. So in his studies, he has described that a perineal incision is made, the stone is extracted, but because of the lack of suture materials and everything, generally it used to be a slow, painful death for the patient. Then we have our own very own Sushruta. He's known for his book Sushruta Samahita. In that, he has described more than 300 surgical procedures, including perineal lithotomy. Again, in Omnius of Alexandria in 276 BC, was the first person to suggest that the stone can be crushed before removing the stone, and that helped to reduce the incision size. But again, it was a difficult procedure. The first recorded removal of a suprapubic lithotomy was carried out during the Renaissance period in 1561. Now, after that came the era of open surgery. Though these were open surgeries, they were not performed with the entire surgical technique. And when the surgical technique came, the first pilotomy was performed by Heineke in 1879. The first nephrolithotomy was carried out by Lee Dentu in 1881. Centenary is credited with the first to suture a nephrectomy incision in 1887. So till that time, all the incisions were not sutured, they were left open, and the patients are generally presented with fistulas. Max Brodel was first to determine the avascular plane in the kidney in 1901, and that helped us to extend the incision in a avascular plane doing nephrolithotomies. Smith and Boise from USA introduced and popularized anatrophic nephrolithotomy for the treatment of staghorn stones. Now, after the era of open surgery came the era of scopes. Nidze cystoscope and the Hopkins rod lens system, Young and Mackay were able to develop cystoscopic lithotrite. So these were the individuals who had first started using a cystoscope. They were first to perform in 1912 a cystoscopy and use a cystoscope to break the stone, and then a ureteroscopy, which was first done in 1929. All these instruments, the diameter was big, the channel size was big, and later the miniaturization has started. Electrohydraulic lithotripsy was first introduced as an intracorporeal lithotripter by Yutkin. He was an engineer for Kiev in Russia. The first ESWL machine was developed by Dornier in 1980, which has revolutionized the treatment of stone. The development of laser for breaking down a ureteral calculi was first initiated in 1986. Next came the popular procedure of PCNL, and it was an era in itself. Ruppel and Brown first removed the stone in 1941, It was removed through a nephrostomy tract, which was created surgically. So basically, a incision was taken, a tube was placed into the kidney, the incision was sutured, and then that tract was used to remove the stone surgically. Tranter in 1948 first used cystoscope through the PCNL to the nephrostomy tract. In 1976, Frenchtom and Johnson were first to describe a technique of extracting renal stone through a percutaneous nephrostomy, which was initially placed by a under radiologic control. As we all know, Kurtz Amplats, these are basically the Amplat sheets that we are using. He was an interventional radiologist. He had numerous innovations under his name, but the popular Amplat sheet that we use was basically a cylinder, a tube which was placed from the skin into the kidney. It was a percutaneous approach, and that approach was again used to pass a cystoscope inside and then remove the stone. It was also done with the help of Smith, who has coined the word endourology. This was followed by miniaturization, where after a standard PCNL, we had a mini perc, and now we are doing a micro perc. Then came the era of flexible scope. Now, as you know, this is a flexible scope. Again, the miniaturization has occurred in flexible scope. In a flexible scope, the scope is passed from the urethra into the bladder, into the ureter, into the kidney. All the calyces of the kidney are checked for stones, and if there is any stone, a it's fragmented with lasers. Now, where does the future lie? The future lies in digital scopes. Though presently the digital scopes, the diameter is on the higher side, but yes, we will be having miniaturization. Lasers, there has been a significant improvement in the laser. There are new techniques being developed in the laser, be it for retropulsion in the form of the Moses technique, or it can be a thulium fiber laser, which has minimal or at least no retropulsion. Further miniaturization, we are going to see further miniaturization in all the scopes that we are using. We went on from an open surgery to an endoscopic surgery, and now we are going more towards miniaturization, which is called as a no-hole surgery. Thank you. I would like to invite Dr. Sandesh Parab. He will be talking on bothersome urinary symptoms in elderly males. Dr. Sandesh Parab is working with us as an assistant professor.
Good afternoon, seniors and my colleagues. Topic for my today's presentation is bothersome urinary symptoms in elderly males and its effective improvement in quality of life after its treatment. When we think of urinary symptoms in elderly males, we think of prostate and its benign prostatomegaly and its symptoms and its treatment. So let's learn about prostate first. So this is a general structure of male genitourinary system consisting of bladder, then prostate, urethra, testes, vas deferens, etc. So what is prostate exactly? Prostate is a small walnut-sized gland. It is a part of a male reproductive system. It produces a fluid which forms a part of semen. So, and what is BPH? BPH is a benign prostatic hyperplasia. It is a non-cancerous benign growth of a prostate gland. Why does BPH occurs? It is because of the androgen excess, and it happens over the period when patient become more than age of 40 years. Testosterone is converted into dihydrotestosterone, and it causes cell proliferation and increase in the prostate size. So because of prostate hyperplasia, there is a bladder outlet obstruction. There is detrusor. Because of that, there is a detrusor response, and patient gets symptoms because of BPH. These symptoms are called lower urinary tract symptoms. These are of two types, irritative and obstructive. Sometimes patient also present with complications of BPH, such as acute urinary retention, UTI, bladder calculi, etc. What are the irritative symptoms? They are mainly frequency, urgency, urge incontinence, and nocturia. Urge incontinence is a urgency followed by leaking of urine before reaching to the toilet. It is very bothersome to the patient, and mainly BPH patient comes with the obstructive symptoms such as weak stream of urine, straining at the time of urination, hesitancy, that is stopping and starting of urine again and again, and terminal dribbling of the urine. So there are irritative symptoms and obstructive symptoms. So if we think of the definition of BPH, it is a clinical syndrome consisting of three things. One is lower urinary tract symptoms, benign prostatic enlargement, and bladder outlet obstruction. The BPH could be a simple disease, but it may worsen over the period. In 55% patient, it worsens. In 30%, it may remain stable, and hardly in 15% patient, it may improve also. What happens if disease progresses? It can cause worsening of the urinary symptoms. It can cause urinary infections, stones. It can also cause renal damage. It may present as an acute urinary retention over the period, or it may need emergency surgery. So LUTS has also been associated with a sexual dysfunction. This has been suggested that sexual dysfunction increases with the severity of the LUTS. So the BPH affects multiple aspects of the health. So we should diagnose the BPH, treat it properly. So how can we diagnose the BPH? Obviously, with the help of history of lower urinary tract symptoms. Then there are other parameters also. One of the important is digital rectal examination. Though it is a less accurate, it used to for the consistency and symmetry of the prostate rather than its volume. And it also can the prostate size can also be graded with the help of the digital rectal examination in from grade 1 to 4. So IPSS score is one of the important tool in learning the patient symptomatology. It is called as a International Prostate Symptom Score. This is a questionnaire based score, and it assesses the severity of the urinary symptoms. This helps in planning the treatment, also giving the assessing the response to the treatment over the period. So these are the various components of the IPSS score. And it can be graded into 3 categories: mild score, moderate score, or severe score. The total score is 35. Mild score is 1 to 7, moderate score is 8 to 19, and severe score is 20 to 35. So another important tool we use is uroflowmetry. In uroflowmetry, on left side, you can see a private cubicle where the machine is kept, flowmeter is kept, in which patient voids urine. And the sensor at the bottom detects the flow of urine, and it gives a graphical representation on a printer, which can be seen as like this. This is in orange color. You can see a normal flow pattern of urine flow. In BPH, in patient of BPH, the flow pattern is slightly plateaued, and there is slight terminal dribbling. Then what are the treatment options for the patient? Patient can be kept on a watchful waiting, or patient can be given a pedicle therapy, or there are surgical options. So watchful waiting can be done in patients with who are asymptomatic or has very mild symptoms. But most of the patients having moderate to severe patient symptoms, and a patient having bothersome symptoms should be treated with the medical therapy. So medical therapy comprises of 3 things: alpha adrenergic drugs, 5-alpha reductase inhibitors, and combination therapy. So what are these alpha adrenergic drugs? Alpha receptors, mainly alpha 1A receptors, are present over the bladder, neck, and prostate. The mechanism of the alpha blockers is they block the sympathetic activity, they relax the prostate and bladder, neck, smooth muscles, though there is no effect on the disease progression. Though they improve the urinary flow and reduces the bladder outlet obstruction and symptoms. They do not affect the prostate enlargement. They are classified into 3 generations. We mainly use 3rd generation drugs, that is tamsulosin, silodosin. We also use alfuzosin in our practice. So these are the various parameters by which these important drugs can be categorized. The pharmacological selectivity, if we see, the silodosin has a greater selectivity for the alpha 1A receptors. The benefits of this treatment with alpha blocker is they rapidly improve the urine flow. They reduce the symptoms of the lower urinary tract symptoms. They give a similar efficacy over this class of drugs, but there is a modest effects on sexual dysfunction, but except tamsulosin, which can cause retrograde ejaculation and can cause problem. There are other adverse side effects also, such as posterior hypotension, tachycardia, sedation, etc. But these are the primary drugs which can be used. Tamsulosin is superior to its colleagues in a way that it has a selective action on prostate. It has less action on blood vessel, and hence less hypotension. It has a better safety, and there is no need of dose adjustment like terazosin or doxazosin. So it is a drug to be taken at the same time of a day of a dose of 0.4 milligram, and should be taken 30 minutes after after the food. Alfuzosin is also one of the commonly used drug in a practice, a dose of which is 10 milligram once a day, and it is to be taken immediately after food. So now newer drug is silodosin, which is now commonly used by the urologists. Why silodosin? Because of its selectivity, sustained efficacy, and safety. It has a selectivity of 162:1 for alpha 1A receptor. So this is which can be seen on a graphical representation also. Silodosin also has a high receptor subtype selectivity and high tissue selectivity also, which is 200 times higher affinity for prostatic tissue than aortic tissue. It has also a safe drug, has no meaningful effects on heart rate, pulse rate, or QRS interval. It does not affect the cardiac repolarization. So though these are the good drugs, but there are some limitations. There is no pronounced effect on alpha 1D receptor, so there is no effect on overactive bladder. There have also some adverse effect, and the important one is they cannot inhibit or regress the size of enlarged prostate. So what is the answer? Answer is 5-alpha reductase inhibitors. 5-alpha reductase inhibitors act. The mechanism is like that: hypothalamus secretes LHRH, which increase the testosterone production, and testosterone is converted into dihydrotestosterone with help of 5-alpha reductase. This 5-alpha reductase is inhibited by these drugs, and there is decrease in DHT, which decreases the size of the prostate. So there are two types of 5-alpha reductase inhibitors: non-selective and type 2 selective. Non-selective is dutasteroid, and type 2 selective inhibitor is finasteride. We mainly use dutasteroid in clinical practice because of its good efficacy and improved reduction in prostate volume of around 26.2%, and the effect is seen after 1 month only. Another good drug combination is of 5-alpha reductase inhibitor and alpha 1 adrenergic blockers. Combination therapy makes arrest the disease progression and rapidly relieve symptoms also. So it is a gain-gain situation for the urologist. So if the surgical medical therapy is not working, there are few indications for surgical treatment, such as recurrent urinary retention, urinary tract infection, recurrent hematuria, or azotemia. So surgically therapy is usually of minimal invasive types, such as transurethral resection of prostate or transurethral holmium laser resection or enucleation. So in TURP, we use a electrocautery, monopolar or bipolar current, and we remove the prostate gland which is obstructing the urethral urine passage. In HOLEP, we use a laser energy for the same purpose. And another option is an open prostatectomy. It is nowadays done for the very large size of prostate or the prostate which are associated with sizable bladder diverticula. Advantage is that lower retreatment rate and more complete removal of the prostatic adenoma under direct vision. But it needs midline incision. It also increases the hospital stay and increase potential of perioperative hemorrhage. So these were the treatment options for the BPH. I conclude my presentation. Thank you. I would like to invite Dr. Priyank Kothari, Assistant Professor in our department, for his presentation.
Good afternoon. Thank you for the opportunity. I have been a Nair alumnus since I was in UG during my MBBS days, and now a super specialty from Nair, and now a lecturer at Nair. So it is a big movement, this the centenary. I am going to talk on two basic things just to clear some of the misconceptions among my colleagues of other departments and also among the different general population. First will be on man's sexual longevity, where I would clearly proclaim that age is just a number. What people have a clear misconception, rather they do not look into it in more detail, is that at the age of 50 to 60 years, sexual health and sexual activity is non-existent and can be ignored. The absence or inadequacy of sexual function at this age is considered a norm in our society. Nor does the individual bother to take any steps towards improving sexual well-being, nor does anyone bother to ask or solve the problems, and they are unaware that these can be treated. Contrary to this, As an eye opener, according to statistics, 60% of patients and 60% of adults, elderly adults in the 60s are sexually active, uh, 40% in the 70s, and 20 to 30 in the 80s. This is just those who are sexually active. The desire to be sexually active is there among more of them, which not most will be open out in front of everyone. So this impacts the quality of life of men of innumerable men. When inquired personally, even the sexually inactive ones express their desire to have a sexually active and pleasurable life. And the thought of being able to gain a part of the life they lost makes them feel happy and complete. So the erectile function is a combination of various parts. First being the centers in the brain, the amygdala, which is responsible for arousal and desire, followed by psychological factors and emotional factors, which are aroused for particular person of in particular situations. A healthy beating heart and healthy blood vessels and good blood supply to the penis and a good nervous supply, all these combined together and not any individual one, lead to a proper erectile function. And when any of these is dysfunctional, it leads to erectile dysfunction, among which there are psychological factors, hormonal factors, blood vessel factors, and nervous system factors. Inability to achieve a complete erection, to achieve a satisfying sexual experience, satisfying himself and his wife, which is very important, is the crux of normal erectile function. And inability to achieve this is erectile dysfunction, which can be due to the following causes. Now, in an elderly male or even in a middle-aged man, these are the causes which can normal causes in simple language. Diabetes causes vascular narrowing and nerve dysfunction. Increased blood sugar causes this damage. Hypertension, that is blood pressure. Again, increased blood pressure for a long time causes vascular damage, damaging the vessels, even supplying the penis. Deranged cholesterols and lipids lead to narrowing of vessels. Obesity, overweight, it's a pandemic currently, even in India. This increases the chances of diabetes and vascular problems. And psychological problems can be due to stress, anxiety, guilt, low self-esteem, or relationship problems. Hormonal age-related decrease in testosterone, also called andropause, is another cause, and that is also treatable. So we should start with simple changes, which can go in a long way, small steps to ensure that we can reverse this process. First is dietary modifications. Avoid consuming high sugar foods and carbohydrates. Consume more fruits and vegetables, flavonoid-rich foods. Lifestyle changes. Daily 45 minutes of aerobic exercise. It helps increase blood flow, well-being. Meditation helps decrease the psychological stress and relaxes the person. Weight loss, diabetes control with a HbA1c target of less than 6.5 in diabetics, and maintenance of cholesterol levels. This was the conservative part. The second part would be counseling, and counseling is important. And the most important is patients from the urologist and patients on part of the patient. A psychological barrier may need empathy and sympathy and counseling, and assurance that the problem can be solved by the simple steps. And also there are basic medications ahead. Relationship stress might require counseling too. So the oral treatments increase blood supply to the penis. This can be taken either 1 to 2 hours before intercourse, or daily tablets are also an option. They have a few disadvantages of headache, blurring of vision, flushing, and feeling of warmth, but people get used to it. The patients in our clinic get used to it and do not complain of interference in their lifestyle. None of them have any consequences on health and have temporary side effects due to increased blood supply to various areas. Self-injection into penis. Oh, when you think about that, it seems very scary initially. But many patients in our clinic, after being taught, are successfully self-injecting and having pleasurable relations. And this injection is by an ultra-thin needle, which just feels like a small skin prick. And there are no side effects, as these drugs do not enter the blood and stay locally at the penis. A penile prosthesis is this is the 3-piece prosthesis, inflatable prosthesis. So basically, for it is 2 tubes are inserted into the penis. The two tubes which are there in the penis as cylinders, and there is a pump which is there in the scrotum. So this can be activated. The man can have intercourse and again deactivated by activating another pump. But these are expensive. So we have other option. This is Shah's penile implant developed by Dr. Rupen Shah. This is made in India, low cost but equally effective. Low cost meaning comparatively it is economically accessible to almost all the population base in our country. And this is simple silicone tube which is different rigidity with a stiff distal tip which helps in intercourse and flexible in middle which can help in concealment when the patient is not sexually active. So to conclude, age is surely just a number. Active motivated ways at any age desire can have pleasurable sexual life. It's a very important component of one's quality of life. This was the first part. The second part will be dispelling myths about male infertility. So I will go one by one myth after the other. Myth one: my wife is not getting pregnant. Definitely there is something wrong with my wife's ability to conceive. Second, I'm having regular sex since 6 months, but my wife is not getting pregnant. Am I infertile or is my wife? So infertility is not a woman's issue alone. Both male and female factors are responsible equally. 1/3 of the cases are due to male, 1/3 due to female, and 1/3 both factors are a cause. The second myth: in 3 months, the husband is anxious why he's not able to conceive. Normally, for a normal couple, it takes 38% of couples conceive in 1 month, 68% in 3, and 81% in 6 months, and 92% in 12 months. So any evaluation for infertility should not be started before 1 year duration of regular unprotected sexual intercourse. So now myth 3: infertility and impotence are the same condition. And myth 4: smoking doesn't affect male infertility. Impotence is an inability to achieve an erection adequate to successfully complete intercourse. Impotence is the inability to achieve an erection adequate to successfully complete intercourse. Infertility, on the other hand, is inability to conceive for the first child, or sometimes even after conception, inability to conceive for the second or subsequent child. Male and female factors combined are responsible. Characteristics of sperm are sperm motility, that is how fast it moves. Once it has entered the female tract, it has to move towards the egg. The sperm morphology, that is the shape, and then the sperm counts, that is how many sperms are present per unit area. So smoking has toxic fumes containing nicotine. This nicotine reaches the blood and then the testes and damages the sperms while they are being produced, leading to decrease in sperm count, morphology, and motility. Myth 5: greater the abstinence before sexual intercourse during fertile period, the more are the chances of conception. And this, there are no sperms in the semen. Does that mean I can never conceive? So longer abstinence leads to accumulation of sperms in the tubes carrying the sperm, and many of them die or lose motility, leading to poor quality ejaculate. Several millions of sperms are produced each day, and 1 day abstinence maintains normal sperm count in most cases. 1 to 2 days abstinence during fertile period is advisable to have the best chances. Prolonged abstinence should be avoided. No sperm in the ejaculate, also called azoospermia in medical terminology. This is also treatable. If obstruction within the passage of sperm transport is found, it can be corrected and natural conception is possible. If testis production of sperm is defective or sperms do not appear in the semen, sperm can be directly taken from the testes and injected into the female egg in laboratory, as in the test tube baby IVF, which is so popularly known. By this method, even very small testes, even the size of peanuts, sometimes have been cut open and sperms have been found in 40% cases. Myth 7 is taking testosterone will help improve my sperm counts. Oh, definitely not. This is completely contrary. Testosterone supplements decrease the sperm count. Wearing tight underwear at night protects my genitals. Wearing tight undergarments increases scrotal temperature and negatively affects sperm production. This is another important myth. Fertility is not linked to overall health, and males' weight and lifestyle have no effect. Now, this is very interesting that the increased weight in men has been associated with a lower testosterone level, poor sperm quality, and reduced fertility. The odds of infertility increases by 10% for every 9 kg a man is overweight. Sedentary lifestyle, poor dietary control, and increased workplace and lifestyle stress are directly related to decreased fertility. Daily 45 minutes exercise, meditation, and dietary modifications have shown to improve sperm counts in many studies. Now, last few ones are left. There is nothing that can be done if a man has a low sperm count. That is also a myth. Medical therapies with antioxidants, multivitamins, and minerals can improve sperm count. Varicocelectomy, if varicose is large, can improve sperm count, and if no improvement with medication, test tube baby can still help conceive. Laptops won't affect male infertility. That is a myth. The heat exposure can result in lower quality, less motile sperm. This isn't just confined to laptops though. And these laptops should be used on desk. And if they are using on the lap, something should be placed underneath to protect the testes. So as we can see, low physical activity, even caffeine intake has been implicated in oxidative stress. High fat diet, low fruit and vegetable, high temperature, all leads to sperm DNA damage or sperm damage in the simple words, which leads to decrease in sperm quality and can lead to male infertility. The last myth, I kept this last because unlike women, a man's fertility does not change with age. No, even that is not true. Male infertility isn't age proof. The quality of sperm decreases with age and it takes longer to achieve a pregnancy. Whatever the age of the mother, the risk of miscarriage is higher if the father is over 45. Children of older fathers are greater risk of autism, mental health problems, and learning difficulties. So this is a graph which shows that the ability to conceive decreases as the age increases, especially beyond 35 years. So to conclude, these are the various factors which I described and the various myths, and these factors can lead to infertility, but most of these factors are treatable and correctable. Thank you for the patient listening and for this opportunity, and hope that Nair has makes 500 years maybe in the future. If any doubts regarding the presentation can be asked on the following email IDs, and we have our andrology OPD which was started in January on Wednesdays and at 11 a.m. to 1 p.m. in OPD 119. Thank you for the opportunity. I would like to invite Dr. Prasad Brahme to speak on urological problems in the newborn. And he's our third year resident.
Good afternoon, everyone. My name is Prasad Brahme. I've done my MS General Surgery from Nair Hospital, and currently I am third year MCH Urology resident. I would like to thank my mentors, Patak sir and Mukund sir, for giving me an opportunity to speak today in this event. I'll be speaking on understanding common male genital anomalies. I'll be taking up a couple of male genital anomalies. So to begin with, undescended testis, that is when the scrotum is empty. So what happens under normal conditions? The testes are two organs that hang in a pouch-like skin sac, the scrotum, below the penis. Normal testes form early in a baby boy in the abdomen, and they descend or drop down into the scrotum towards the end of pregnancy. This is controlled by the baby's hormones. The testes are where the sperm and testosterone are made. So what happens in undescended testis? The undescended testis is when it fails to drop into the normal space into the scrotum, as we can see on the right side, while on the left side it has dropped down into its normal place. So what are the causes of undescended testis? Even though it is not clearly understood, there are few risk factors like premature babies, low birth weight babies, babies who have a family history of undescended testis, and few chromosomal abnormalities like Down syndrome. So is this condition very rare? It was seen in an Indian survey that almost around 85% of the studied population were not aware about this condition. But the answer to this is no. It is the most common birth defect involving the male genitalia. Incidence is almost 3% seen in full-term babies, while in 30% of premature infants. The positive fact is approximately 80% of undescended testes descend by the third month of life. So how is it diagnosed? It is diagnosed by medical examination by checking the scrotum. It can either be a palpable testis or a non-palpable testis. The non-palpable testis can either be undescended, or there can be no developed testis at all, or it can be a retractile testis. So what is a retractile testis? It is important not to confuse it with undescended testis. After 6 months of age, a male child has a reflex that temporarily pulls the testis up to protect them when he's cold or frightened, as we can see in the photo. It goes up and it comes down on its own. So it is important to examine these babies when the baby is calm and composed. These testes are in the scrotum at other times and they do not need any treatment. So hence it is important to differentiate it from undescended testes. So what are the complications of undescended testes? It can lead to infertility, that is inability to conceive. There can be an associated inguinal hernia. It can predispose to some forms of testicular cancer. There can be trauma or torsion of the testes of these undescended testes, and there can be cosmetic or psychological problems because of these. So what are the cause of infertility? The testis needs to be 2 to 3 degrees cooler than the normal body temperature to make sperm. The scrotum is many degrees cooler than the body temperature, and so is the ideal place for the testis. testes that don't drop down into the scrotum hence won't work normally. And the longer the testes are too warm, the lower the chances that the sperm in the testes will mature normally. And this can be the cause of infertility, especially when both the testes are affected. So is it always necessary to be treated, and what is the exact time? So the testes usually won't drop down after 6 months of age, and the only treatment of choice after that is surgery. Surgery is recommended between 6 months to 18 months of age. Treatment before 1 year of age might lower the risk of complications of an undescended testis, such as infertility and testicular cancer. The surgery done is called orchiopexy, in which there is manipulation of the testis into the scrotum and it is fixed there. And the success rates ranges almost around 100%. A few things about hormonal treatment. A hormone treatment involves injection of human chorionic gonadotropin, which helps in movement of the testis into the scrotum, but it is not recommended because it is less effective than the surgery. Now, prior to surgery, there are few things that we need to understand. If the testis can be felt either in the groin or just near the scrotum, a cut will be produced in the groin and it will be repaired. If the testis cannot be felt, we will first look into the abdomen and the groin with a laparoscope. If the testis is very high up, a 2-stage repair may be required. And if the testis is very tiny and non-functional, it may be best to remove it. So now a few details about inguinal orchiopexy. A small incision is given into the groin. You locate the testis, make sure that it is healthy. A second incision is given into the scrotum and a pocket is created and the testis is fixed into it. Now, when a testis cannot be palpated, you need to do a diagnostic laparoscopy. That is, a camera is inserted through a small incision in the abdomen. Laparoscopy is done to locate an intra-abdominal testis. Testis is attempted to be brought down into the scrotum and fixed. In few cases, the testis is very high up and a 2-stage repair may also be required. So to summarize, it is a relatively common finding. It should be treated. Orchiopexy between 6 to 18 months is the treatment of choice. There are increased risk of infertility and testicular cancer, and regular post-op follow-up is necessary, and patient should self-examine it. Now, coming to another topic as hypospadias. Hypospadias is a congenital defect of the penis in which the urinary tract opening or the urethral meatus is abnormally located on the undersurface of the penis, as we can see in the photo. There are few associated findings along with hypospadias, as there could be a redundant foreskin on the upper side of the penis, or there could be a downward curving of the penis due to dense fibrous tissue which pulls it down. So how does a penis normally work? The main roles of the penis are to carry urine and sperm out of the body. The urethra is the tube that carries urine and sperm through the penis to the outside. And the opening to this outside is called a meatus. So both these tasks are easier when the meatus is at the tip of the head of the penis. So now what happens in a hypospadias? So as we can see in the photo, it is like a tap which is leaking from the undersurface. There is passage of urine from the undersurface of the penis. There is poor stream and spraying of urine. The baby might need to squat while passing urine. There can be downward curvature of the penis, multiple times urinary tract infections, and abnormal looking genitalia. So these are few types of hypospadias which can be differentiated depending on the opening, how far away it is from its normal opening on the undersurface. So does hypospadias need surgery? Yes, most of the hypospadias do need surgery. The final decision rests with the parents and the doctor. If the child is functionally and cosmetically looking normal and the opening is very near to the normal opening, then the surgery may be avoided. So why does it need a surgery? It can be for cosmetic purposes or a functional purpose, like if there is a small opening causing back pressure changes, excessive curvature of the penis, poor urinary stream, or if the patient is demanding surgery. And the ideal age for surgical repair is between 6 months to 18 months, considering whether the baby can tolerate anesthesia. What will happen if it is not repaired in severe cases? There can be irregular urine stream. He would have to pee down, sitting down his whole life. His penis would look different than the other boys, causing him social embarrassment and low confidence. If there is a cordy, it becomes very painful, difficult, or even impossible to have a sexual intercourse as an adult. Can boys with hypospadias be circumcised? The circumcision is removal of the foreskin, the tissue which covers the head of the penis. So the boys who are born with hypospadias or genital anomalies should never be circumcised because the extra tissue of the foreskin may be needed to repair the hypospadias during the surgery. What are the goals of hypospadias repair surgery? It is to make a normal, straight penis with a urinary channel that ends at or near the tip. And the operation mostly involves these 4 steps: straightening the shaft, creating the urinary channel, positioning the meatus in the head of the penis and reconstructing the foreskin. What type of surgery is needed? It depends upon the type of hypospadias. It can be a single stage repair for simple hypospadias where the opening is near to where it normally should be, or a two-stage repair is reserved for complex varieties when the opening is far away from its normal place or in some redo procedures. What are the complications of hypospadias repair? It can cause wound infection or dehiscence, flap necrosis if the vascularity is being compromised. As the tissue in the penile region are very delicate, it can lead to edema, urethral fistulas, and recurrence. The journey from a squatter to a pointer might look like an uphill task, but with an early diagnosis, appropriate counseling, suitable and meticulous technique of repair, and judicious post-operative care, success can always be achieved. Thank you. I would now like to invite my fellow colleague, Dr. Neil Patel, who is doing a third year MCH Urology in Nair Hospital.
Good afternoon, everyone. Myself, Dr. Neil Patel. I'm third year MCH Urology resident. I would like to thank Dr. Pathak sir and Dr. Mukund sir for giving me an opportunity. Today, I will talk about the conservative treatment of the common pediatric urological ailments. First thing is the anuresis, bed wetting in the children. What is the anuresis? What does it mean? Anuresis is defined as the repeated voiding of the urine into a clothes bed at least twice a week or at least 3 consecutive months in a child who is at least 5 years of age. What are the epidemiology of the nocturnal anuresis? At the age of 5 years, 7% of the boys and 3% of the girls have anuresis. By the age of the 10 years, the percentage are reduced approximately 3% and 2% respectively. Girls typically acquire the bladder control before the boys, and the bowel control typically achieved before bladder control. The spontaneous care rate of the anuresis is approximately 14 to 16% annually. What are the causes? The causes of the aneurysm, like it involves the biological, emotional, and the learning factors. Psychological stressor may be contributory. It all depends on the sleep pattern of the child. Nocturnal aneurysm is not the child's fault. It involves the family predisposing the genetic role, family predisposing the condition, physiological disorder in the voiding control, stressful hormone life, conflict between the parents, starting school, moving to a new home, or the attention deficit hyperactivity disorder. But they're not the cause but influence the treatment outcome. Evaluation. Routine history and the physical examination are required. It could be associated with the urinary tract infection, chronic kidney disease, spinal cord disorder, constipation, or the diabetes. In that case, we have to require the urine routine examination. The voiding diary, helpful in the identifying the underlying bladder dysfunction. Baseline records of the aneurysm pattern. Typically, voiding diary is when how much the urine, how much the water intake, how much the urine passes by the child with the chart. Goal of the treatment. What is the goal? To start the dry on the particular occasion. Example, sleepover, to reduce the number of wet nights, to reduce the impact of the aneurysm on the child and the family, and to avoid the recurrence. Treatment. Treatment can typically begin with the parent-child education, charting with the revivals for the dry nights, every dry nights, voiding before the bedtime, night awaking 2 to 4 hours after the bedtime, making sure that parents do not punish the child for aneuritic episodes. The most important treatment option is the behavioral intervention. This includes the simple behavior interventions, behavior or action that can be achieved by the child without a great effort. And the second one is the complex behavior intervention, multiple behavior intervention which requires great effort by the child and the parents to achieve, including aneurysm alarm therapy. If the constipation and the fecal infection are the problem, children should be encouraged to have daily bowel movements to toward the optimal relaxation of the pelvic floor muscles to improve the bowel emptying. If this approach fails, urine alarm treatment, it's also called the conditioning regimen, is recommended. The success rate of this is 75 to 95%. Basically, in this, the urine alarm treatment, there is a sensor. It typically sensors the drop of the urine. The sensor alarm basic unit that alarm sounds the child wakes up, train the brain to how to when to child need to go to the toilet. The medications. The pharmacotherapy for the nocturnal aneurysm is the second line treatment. The most common drug used, the desmopressin, is a synthetic analog of the antidiuretic hormone, which decreases the nighttime urine production. The relapse rate is high when the desmopressin is discontinued. Less commonly used drugs are the oxybutynin and the tolterodine. When does the indication for the urological referral and the treatment includes that it's a daytime wetting, abnormal voiding, unusual posturing, discomfort, straining, and the poor urine stream, history of urinary tract infection and evidence of the infection on the urinalysis, and the genital abnormalities. The second talk is on the what is the antenatal hydronephrosis. Basically, the antenatal before the birth hydronephrosis is the fluid-filled enlargement of the kidney, can be detected in the fetus by ultrasound as early as the first trimester of the pregnancy. What is the epidemiology? By sonography, 1 out of the 100 pregnancy present with the fetal urinary tract dilatation, and 1 out of the 500 are diagnosed with a significant urologic problem. The left kidney is more commonly affected than the right kidney. What are the clinical presentation for the death? Child should be presented with the palpable mass in the newborn. Antenatal hydronephrosis is present in 80% cases, and urinary infection in the blood in the urine. And it can be later in the life, the episodic abdominal pain and the vomiting. Associated anomalies with the antenatal hydronephrosis, approximately 50% other urological abnormalities can be detected during the sonography. How it could be diagnosed? It could be diagnosed by the ultrasonography and the diuretic renography. Diuretic renography is the confirmatory test for diagnosis congenital UPG obstruction. Ultrasonography, USG can detect the fetal bladder and kidney by the 15 weeks of pregnancy. APD, anterior posterior diameter, is the most commonly studied indicator for assessing the antenatal hydronephrosis. Antenatal hydronephrosis is present if the anterior posterior diameter is more than 4 mm in the second trimester and the more than 7 mm in the third trimester. What are the grades for hydronephrosis? There is a mild hydronephrosis. The pelvic anterior posterior diameter is less than or equal to 1.5 centimeter. The moderate hydronephrosis, wherein the diameter is more than 1.5 centimeter without any parenchymal atrophy. What are the severe hydronephrosis? Severe hydronephrosis is indicated when the anterior posterior diameter is more than 1.5 centimeter and associated with the cortical atrophy. Normal classification in the second trimester and the third trimester. Mild is 4 to 6 mm. In third trimester is 7 to 9 mm. Moderate 7 to 10 mm in the second trimester, 10 to 15 mm in the third trimester. Severe is more than 10 mm and the more than 15 mm in the third trimester. Diuretic renography. Basically, it is performed to differentiate between the obstructive versus non-obstructive hydronephrosis. Obstruction will be demonstrated excretion, downward slope on the renogram after the administration of the diuretic from the collecting system. Management, how to manage? Conservative management, 50% of the antenatal hydronephrosis is resolved after the birth. Observation, how to follow up? Sonography and the renal scan every 3 to 4 months for 1 year, then every 4 to 6 months will be required. What is the physiological hydronephrosis is clinically not significant. There is no treatment is required that avoids the unnecessary test, antibiotics and surgery. If there is a complication, obstruction and reflux, treatment will be required, protect the renal function, it permit the growth and develop the avoid complication. What are the indications for the surgical intervention? Presence of the symptoms associated with the obstruction, impairment of the overall renal function, progressive impairment of the ipsilateral function, development of the stone or infection, and the hypertension. Thank you. I would like to invite Dr. Maitreya Joshi, my fellow colleague.
Hello, good afternoon, everyone. I am Dr. Maitreya Joshi, third year resident in MCH Urology in Nair Hospital. First of all, I am very proudful to be a part of this Nair centenary celebration activities, and also very much grateful to our respected HOD Dr. Pathak sir, Mukund sir, and other senior faculties to have been included in this part of all informative talks just we have seen ahead, regarding cadaveric transplant, some newborn urology and andrology, and a part of some childhood problems. But today the most important and most ignored problem in urology is a female urological problems. That is a portion of these problems that is ignored in the societies because that is a lack of awareness, either stigmata of societies or a less education per se. So I would like to discuss brief details regarding these problems as a female urological problems, and let's do go away with these problems of ignorance. Let's go away with ignorance of the female urological problem. So what are the common urological problems? In different age groups, we have some different urological problems. Like in adolescent and middle age group, there is a different type of lower urinary tract symptoms like urgency, frequency. The patient has to go repeatedly in the toilets in the evening, in the daytime, in the day and night. That is nocturia, urge incontinence. Patient has to go in the rush. Sometimes patients have a problem regarding voiding, like a poor stream. But in different age groups, like in elderly women, there is a different scenario. Like there is an stress incontinence. But now let's see details around some different problems. Now, what is the overactive bladder? Overactive bladder actually is not a disease per se. That is a group of urinary symptoms. Most common symptom is a sudden uncontrolled need or to urge to urinate. That is when occur patient leak urine when they feel this urge, and patient have a urge to pass urine many times in day in the night. What happens is just a diagraphical presentation. Like in normal bladder, what happens when the bladder fills with the urine, we have a urge in the micturition. But in overactive bladder, what happens? Even there is a lesser amount of urine, patient has an urge to mix urine and has to go to the toilets. What are the basic symptoms? Per se, there is an urgency that has to get to the sudden urgent to desire to pass to urine. What is frequency? That is in several times in the day and several times in the night. Patient has to wait to go to toilet. That is per se nocturia. That is more. If it is more than once, that is a abnormal. Patient may have urge incontinence. That is losing urine on way to the bathroom in between. Though it can be maybe due to the drugs, caffeine, some addiction like alcohol, or due to the age-related problems. These are some risk factors like diabetes, urinary tract infection, and some hormonal changes occurring routinely in the menopausal age groups. So now, how will we manage this overactive bladder? Some lifestyle modification, medications, and surgical options. The basic treatment protocol and algorithm are: we will initially treating with the non-invasive methods like behavioral therapy, some oral medications like anticholinergic, that is abolishing the different overactive drives in the bladder. And what are the combined therapies? Some behavioral treatment or the counseling part, and some medications, some estrogens for the postmenopausal woman, and some are alpha blockers. There are some minimally invasive treatment like intravesicular injection of the botulism, and some neuromodulations, and some treatment like augmentation and urinary diversion. See, in the behavioral therapy, some fluids or the intake, they should be avoided, and what are to be the favored, like drinks in the alcohol, tea, coffee, caffeine, and some stress that may cause the overactivity in the bladder, and that may be the culprit in these overactivities. So what are the commonly used medications in the market? Different pharmaceutical companies make with the different brand names, but the commonly used by the urologist and some surgeons, solifenacin, derifenacin, mirabegrons. These solifenacin and derifenacins are the anticholinergics. They usually abolish the overactive drives. Actually, the cholinergic drives are the responsible for the overactivities. So these anticholinergic drugs usually abolish this drive, and mirabegron is a novel drug introduced before in the several years. That is actually a beta-3 agonist, and there is a important step in the management of the overactive bladder. Surgical. What is surgical management? Though some patients may not respond to their drugs or medications, they are very resistant, and in these patient age groups, we may try intravesicular injection of the botulinum. That is bladder with the filled with the sterile bottle, and very few injections of Botox are placed in the wall. It actually takes 5 to 10 minutes, and it is in a durability of the 6 months. The patient may need another 6 monthly injections, but it has a very good responsive rate of 70 to 80%. Now, another most important problem in the society is usually in the older age groups is the stress urinary incontinence. So basically, what is per se stress urinary incontinence? Stress incontinence is nothing but the losing urine in spots or the gush with several activities like raising from the bed, coughing, laughing, lifting some even a small trimal weight. It may be caused by the repeated deliveries, multiple deliveries, childbirth, some instrumentation during deliveries, or age related, maybe growing older. See, in the normal bladder, sphincter is a part of it is a muscle part that prevents urine to come out with abdominal pressure. But what exactly happens in the SUI bladder is this muscle function is deranged, that is not competent enough to hold urine inside the bladder without the urge or voluntary contraction. So patient can void without any urge of urine in between with even a trivial abdominal pressure activities like coughing, laughing, and lifting certain weights. See, if you have stress incontinence, you may leak with certain activities like, as we have just mentioned, cough, laugh, bend over, lift, even while exercise, or maybe even during sex. These are the risk factors like in the older age, multiple vaginal deliveries, instrumentation, previous perineal or pelvic surgeries, and patient may, chronic smoker may also develop like these problems. Several treatment just in the overactive bladder. There is also behavioral treatment and some medications like weight loss. Fat females may develop such problems usually. So weight loss is the important elements and the treatment of chronic cough. Some physiotherapies like pelvic floor muscle training, Kegel exercise is also important part. But in surgical part, there is a mid-urethral slings, some periurethral bulking agents has been tried and is very successful in those group of peoples. What is Kegel exercise? It is a very good part of public education in these age groups because actually this is apart from medication, important part in the initial treatment of this SUI. Basically, two pelvic floor derangement is there in this abnormality. So we want to try to strengthen pelvic floor muscles. That is usually a first step. Different exercise has been figured out here how females can try in even their homes and try to strengthen the pelvic floors. See, surgery is basically we are advising in certain females. There is a definite diagnosis of SUI with failed behavioral modification and some lifestyle modification and no different contraindications. So we are very commonly and very famous surgeries are routinely performed by urologists and or by gynecologists. These are sling surgeries. Sling surgery usually done by, that is also not a major surgery performed in the minimal invasive routes by TOT means transobturator route or the transvaginal route. The most popular are the actually a slings or the band of synthetic mesh we can put below the mid urethra because there is a urethra is descending in this problem. So we have to support the urethra to decrease the loss of urine. It is basically nothing but the small incision in the roof of vagina and beneath the mid urethra. We will by just incorporating the needle, we are putting a mesh or the sling or beneath the mid urethra, and from see in this figure we can see we can do this procedure by supporting mid urethra from this obturator route or a vagina route. This is a surgery very commonly performed and having a, if not otherwise, it is a very good successful. Thank you.
Since the lectures are over, I would like to invite Dr. Hemant Patel to give a vote of thanks.
Yeah, dear friends, on the auspicious occasion of this centenary month of BYL Nair Hospital, our department took this initiative in trying to have a educative program for basically a non-urologists and general public on various aspects in urology. I thank each one of you, my colleagues, Dr. Mukund, Dr. Tarun, Dr. Sandesh, Priyank, Prasad, Neil, Maitreya, and also very, very important, those who have not been today on the dais, the senior registrars, the SMOs, Dr. Jitendra, Tushar, Suraj, the exam going batch, the final year residents, Dr. Abhish, Naresh, Siddharth, and of course the young batsmen, Pradeep Jain, Deep Joshi, and Chetan Tikar. So I thank each one of you and also our theater staff, the urodynamic staff, our ward staff, without which the patient care is just not possible and complete. Also, I would like to announce that we'll be holding one camp in the last week of this month. It will be on the prostate awareness program. So it will be about making patients aware about the benign enlargement of prostate and also detecting malignancies. Thank you. Thank you, each one of you.